Hi, my name is David Elstein, and this is the American Board of Orthopedic Surgery podcast. Each episode is designed to help busy orthopedic surgeons learn more about the ABOS and board certification. On this episode, we're going to talk about the ABOS Oral Recertification Examination. While most ABOS diplomates participate in the ABOS web-based longitudinal assessment pathway, some take an ABOS computer-based recertification examination. The ABOS also offers oral recertification examination as a knowledge assessment option. So with us is Dr. Dane Salazar, orthopedic surgeon in Illinois. Last year, Dr. Salazar took and passed the ABOS oral recertification examination. As he had already met the other parts of the ABOS continuing certification program, he recertified for another 10 years. Dr. Salazar will discuss why he chose the oral recertification examination and how he prepared for it. So, hi, Dr. Salazar. Welcome to the podcast.
Thanks for having me. I appreciate the invitation.
You're welcome. Can you briefly describe your current practice and what your typical case mix looks like?
Yeah, so I am an academic attending at a level one trauma center. I practice here at Loyola University Medical System in Chicago. My practice is almost 100% electively shoulder and elbow. I take level one trauma call and still fix fractures and do hip fractures, ankle fractures, washouts, that type of thing. But my elective practice is mostly shoulder and elbow arthroplasty, shoulder and elbow arthroscopy, some nerve work, some tendon work, but mostly upper extremity.
Okay. So, just get right to it. Why did you select an oral recertification examination?
Yeah, a little bit unusual. I mean, some of it was strategic and some of it was convenience. The convenience part is obviously I live and practice in Chicago and the oral boards are here. So I didn't have to travel. There was no overnight stay. I actually walked to the board exam. I saw a clinic the same day I took my oral board recertification. So I actually only had to cut out a half day at clinic. So I wasn't missing a lot of work for travel. And there wasn't a lot of personal expense associated with it. So that was kind of the convenience of it. The strategic part of it is that I had been faculty on the AOS Part 2 board prep course for many years and aspired to be an ABOS board examiner myself. And as an academic surgeon who trains people that take this exam, I felt like I wanted to go through that process so I could be closer to it and sit in their seat and experience that. I also, as part of my continuing medical education each year, as the self-assessment exam part, I actually take the OITE so that I can see what the resident trainees are seeing, what questions they're being asked. I think it makes me a better teacher and allows me to counsel them a little bit better about the process. And so for me, it had been now a decade since I went through that process personally. And so I felt it would give me some credibility with some of my talking points and some of my coaching if I had just recently undergone it myself.
That's great. All that makes sense. But I guess did you get any colleagues sort of questioning you, ribbing you for taking that when there are quote unquote easier options out there?
Yeah, probably all of the above. And there was definitely time points where I thought, oh man, I could have just taken 5 tests and done this. And for me, again, it wasn't any angst about presenting my cases or going through the oral process. The more arduous part was actually uploading the documentation. And my original thought process was, well, I have to collect 75 cases anyway. It's not going to be that much more work to upload the cases that are selected for oral boards. Well, that process was a little bit more arduous than I had originally in my mind thought it was going to be. You kind of block out the oral boards the first time you take them. You say that wasn't that bad, and the reality is that was the more kind of arduous process. Was kind of coming to my office on Saturdays and uploading MRI, CT scans, X-rays, PT notes, my own clinical notes. But in the end, I was still very happy that I had done it. It again allowed me to be much closer to the process so that A, I can coach and counsel people that are getting ready to go through it, but B, also work with the ABOS to streamline the process. I think that there is value in the ABOS looking at ways to improve how arduous the process is for young orthopedic surgeons to upload their information, especially in the era of the electronic medical record, where a lot of that potentially could be automated.
Yeah, no, I read a lot of good feedback. The board of directors are always looking at ways to help orthopedic surgeons reduce burden, but that's something that will definitely, take back to them. But talking about documents, images, do you have any advice? Did you learn anything about how to upload them that during the process that you'll pass on to the people you teach?
Yeah, I mean, obviously, the more organized you are, the better. And so I would say you want to set up a system far ahead of time in anticipation of your board collection period, and start doing that very early. You don't want to wait to the last minute and procrastinate, and then find that you're behind the schedule and it's taking you longer. I think it's much easier to do it in small snippets. So I kind of said, well, I'm going to do 2 or 3 cases on a Saturday, upload those 3 cases, and then spend the rest of the day doing other things as opposed to kind of burning out myself and taking the whole day. But I would say, being organized, being early, and preparing kind of all of your thoughts. The nice thing about the uploading process and writing the case summary and those things is it actually does help structure your thoughts about how you're going to present to the board examiners, what your thought process was, and kind of talking through the care of that patient. So I actually liked that exercise. It kind of forced me to get all of that down and think about that ahead of time. So I had kind of done the cerebral exercise of presenting ahead of time. And then the day of the exam was really just kind of executing the narrative that I wanted to explain to the board examiners.
Okay, let's pick up that sort of that general topic some more. So how did you prepare for the examination? Talk a little about the physical uploading, but it's more than just putting documents, images online.
Yeah, I mean, obviously, again, a little bit of a unique practice is that I'm in academic medicine. So we're constantly having journal clubs. We have weekly indications examination. I'm constantly reading and writing scientific manuscripts that have to do with shoulder and elbow surgery. So for me, there wasn't a lot of going out and kind of reviewing the current general literature, but certainly for specific cases, I would go look up recent articles, potentially about outcomes, potentially about complications, sometimes systematic reviews if it was something rare. The one thing that I did on this round that I didn't do a decade ago was that now I do a lot of preoperative templating for my arthroplasty. And so I actually uploaded those documents to kind of show that we use those preoperative CT scans to create three-dimensional models. Sometimes we're even ordering customized implants for the patients. So I wanted the board examiners to get an understanding of the preparation that goes into the thinking of all of these surgeries. So again, I would counsel people that you really want to get credit for all the things you're doing on behalf of your patient. So be very comprehensive about that. If you're calling patients before surgery, if you're calling patients after surgery, make sure you document a telephone encounter to say, "Hey, I went over preoperative instructions the night before, made sure they were MPO, and then I called them the day after surgery to make sure no questions had arisen and that there weren't any complications that I needed to address." And so, again, you want to get credit for all the small things that we as practicing clinicians do for our patients, and you want to document that.
So I guess was the examination what you expected? How did it go the day of?
Yeah, I think for me it was different than the first time. The first time there's a lot of kind of uncertainty, apprehension, angst. I mean, it's a high pressure situation. But what I learned the first time through was that everyone's rooting for you to succeed, and that the goal is to make sure that orthopedic surgeons are compassionate and safe to provide care to their communities. And it's not to trick people. It's not to be punitive in any way. It's to make sure that you're practicing evidence-based medicine in a very safe way. And so that was the take-home point for me the first time was I saw a lot of friendly faces. Terry Peabody, who I knew and worked with, was the person that checked my ID and handed me the pencil, and that really was meaningful to me to say, hey, there's people here that are rooting for you. And this time around, it's even more different because obviously you've been in practice for a decade, and so you see people in the room, you recognize people, and you're also very comfortable with your cases. You've been doing this for a decade, and it comes very easy to kind of to defend your decisions because you have a treatment algorithm that you've kind of procured over years of practice.
No, that's great. And you mentioned about Dr. Peabody checked you in. The board members really take pride in doing it because we have staff members that could check everyone in, and board members say, no, no, we want to be there for it. So yeah, it's definitely, what the board is not trying to fail anyone. It's really, as you said before, to safe, compassionate medicine. I'm glad that, that came across. Um, so any advice for the day of examination for preparation, things that you either did or now you would have done if you now thought about it?
Yeah, I mean, I would just say, trust your preparation. And again, no one's trying to trip you up. Don't overthink it, right? If someone's asking you a question, don't overthink why they're asking you the question. Be honest. Be your own harshest critic, right? If there's something on the X-ray that you would have changed, certainly say, if I had it over, I would have moved this plate or this screw, or I would have been a little bit more varus or a little bit more valgus. As surgeons, as people that do this every day, that's a very reasonable thing, right? We want to be constantly learning. None of us have ever done the perfect surgery. Every board examiner knows that. Again, it's about safety, it's about efficacy. And so I would say trust the process, trust your training, trust your preparation. If it's your first time, I would probably find someone that's either has experience, has done recertification, and run through your cases. The first time you kind of run through your cases should not be the day of the oral exam. You should have kind of walked through it, kind of explained your thought process and your thinking, and gotten some feedbacks from trusted mentors, senior partners, things like that, so that you can kind of anticipate some of the questions that might come along and potentially have some research or data to back your decisions.
Yeah, no, I want to just piggyback on that. And yes, definitely have someone. But at the same time, we always tell people do not find someone that's just going to say, yes, good job. You need someone that we say there's a scoring rubric and looks through all of those things and tells you, okay, what you can prove on. And I guess the other thing to get on is that red flags will go up if you don't have any complications. Yes, maybe if you have a ton, there's possibly red flags, but if there are none, there's the red flags will go up on that. You said document it and explain it.
Absolutely. Anyone that does enough surgery has complications to report, and you just have to be kind of completely transparent about that. And don't panic, right? I mean, there was one of the cases where a board examiner asked me about a post-op follow-up note, and there was a moment where logistically there was trouble kind of finding, and I said, no, I promise I've seen this patient in follow-up. Give me a second. And it was just that it kind of got uploaded in a different folder, and it took me a few seconds, but don't panic. It's there. You've gone through the documentation. Just kind of pivot for that moment, find the document. And I said, yeah, just give me a second. I'll have it for you. Oh, here it is. It's actually in this folder. And then they just said, oh, yep, there it is. No problem. We'll move on. So don't panic, and trust the process, trust your preparation, and then just let kind of your own personality come through.
Yeah, and that's a good. The other thing with follow up, sometimes there's reason that there was no follow up. I mean, especially with trauma thing, and just as long as that's documented. But then the other thing we say is do what you normally would do. You shouldn't do anything differently, whether you're part two or research and collection period. If this is your way of doing it, if the PAC is on the first follow up, that's what it is. Don't change that. Don't change how you practice. Just do what you're normally doing.
That's right.
Yeah. Um, So you sort of hit on any things, but are there any misconceptions that you had colleagues, or since you said you've taught the class before, you get questions and you realize, wait, it's not like what people are thinking. So anything that's misconceptions or false or
Yeah, I mean, I think obviously it is a high pressure environment, and no one's going to deny that, right? This is our vocation, this is our profession. We've spent a lot of time and training to get to that point to be a practicing orthopedic surgeon. So anyone that tells you, "Oh, it's no big deal," that's probably disingenuous. But I think the misconception is that the board is trying to root people out. That the board, that it's like Navy SEAL training and they're trying to get you to ring the bell. And nothing could really be further from the truth. I mean, the board spends an inordinate amount of time making sure that it's fair, number one, and that the scoring rubric is understood. I mean, you are given ahead of time what you're going to be scored on. So as you're compiling your cases, I think it's very important to make sure you're constantly looking at to make sure, am I checking all these boxes for documentation, for professionalism, and so forth, right? And so I think the misconception is that they're out to get me, they're out to find something, they're out to trip me up, and the reality is that isn't true. They're there to review your documentation and review your thinking to make sure that you're taking good care of patients, which the overwhelming majority of orthopedic surgeons do every day in a fantastic way.
yeah, said it better than could have. So you just have gone through this oral examination. Would you do it again? And it's not for probably another 10 years, or you did it, it was good, and you tell the truth. I mean, it's
Yeah. It's an interesting question because I have wrestled with it. And as I sit here today, I probably would choose a different pathway to research. But I do think that that opinion might change in the next couple of years. Again, the further I get away from the process, and if I'm still in academic practice and still, have an obligation to my trainees to coach them, I may decide to do it again and say, it's been almost a decade. The ABOS has revamped this aspect and that aspect, and probably it's time for me to sit and do it again. Again, for me, it wasn't the day of the test that was arduous. It was the uploading, and that may change over time. There may be a different portal. There may be a different avenue. I mean, who knows? 10 years from now, we may have an AI assistant that helps put all of our things into the portal for the board. And so, as I sit here today, I'm not sure I can answer that question for you because I have some time to make it.
right.
But I have no regrets of doing it the way I did it. I actually, it was helpful for me, and hopefully, it's helpful to the residents and fellows that I train to be able to coach them from a standpoint that I recently went through this.
Yeah. And the thing I mentioned before, you just mentioned, constantly changing. You didn't get to experience, but I'm sure you talked to other colleagues that are older that brought in physical records. They brought, talk about a whole suitcase of records, hoping that the airline wouldn't lose it. And now everything, yeah, it is some work, but it's all ahead of time. So you don't have to worry about that. So yeah, 10 years, it's a long time away. So now that you've gone through this and you've been a teacher, have you thought about being an examiner?
Yeah, and certainly I had that thought when I chose that pathway to say I would like to get more involved with the board, and certainly I think it gives you credibility as a future potential examiner to say, "Hey, I sat in your chair very recently. I know what it feels like. I know what some of the thoughts and fears you have." And so again, I think it sets you up uniquely if that's something you choose to be as part of your clinical practice is to be an ABOS examiner. Going through the oral recertification pathway, I think, was very helpful for me.
Great. I guess the final question, sort of a general question. I mean, you seem excited about all this. So what does ABOS board certification mean to you? And I guess also the whole process of continuing certification.
Yeah, I mean, I think it's part of professionalism, right? We want to give the public the reassurance that when they see an orthopedic surgeon, that that surgeon is talented, that they're a good comprehensive physician that's going to offer them high levels of musculoskeletal care. And so I think that's very important because if you don't police yourself and you don't govern yourself, then someone will eventually do it for you. And we don't want that. We want the seats at the table. We want to be governing how we do continuing medical education, how we do recertification. So to me, it's of paramount importance that the ABOS has all of these pathways. And now, as practicing clinicians, we have multiple ways that we can recertify and show the public that we're doing all the right things and that we have the skill level to take care of them.
Thank you, Dr. Salazar, for your time. I think this is people are going to love, listening and hearing all your suggestions for this.
I appreciate it. Thanks for having me. It's been fun.
Yeah. So I just remind people the website, abos.org, has a lot of information when you think about doing the oral exam. Definitely look at our scoring rubric, and pretty much everything said today applies to the part two people as well. And people, if this is your first time watching us, viewing us, definitely suggest subscribing to us. You watch it on YouTube and Spotify. We also on Amazon, Apple, everything. So definitely like, subscribe, and you'll know when the next episode is posted.